Oh, good, it's in the center. So I too am glad that that last talk was positive and optimistic and all of that, because we might balance that out a little bit with this one. Can I just, a show of hands of who was at my opiate talk earlier today and who is not? Okay, the second group looks a lot more optimistic and positive to see me up here. I'll see how bad this goes. Sorry. There. Okay, so disclosures. I'm told that if we don't get direct funding from industry, we don't have to disclose it, but I think it's worth a conversation at some point about how we actually think about conflicts of interest. And we'll actually talk about that a little bit in this presentation. I do receive honoraria for speaking in for advisory functions to Indivior Environics, DPS Original. Those are paid directly into a fund to support trainees in our clinic in addiction medicine, and none of it goes directly to our physicians. I have received fees from the Canadian Medical Protective Association, the CPSA, and the Faculty of Medicine, which means I tend to look for things that people did wrong, and you'll see that as a theme in this talk. And a couple of other things that you can see up there, but the last one that we usually don't disclose is who our employer is if they're not industry. And I think that's important because I have been a public health expert for Health Canada, First Nations, and Inuit Health Branch, which basically means I gave public health expertise to government, and then they did with it whatever they do with public health expertise when it's given to them. And there's always an agenda with every organization, and it's just less obvious and more insidious when you're working inside governments and bureaucracies than when you're working for industry. And I think that, well, the point is that we're always in conflict, and some of those conflicts, you'll see those phenomena playing out with the fentanyl issue here in Alberta. If you're government and if you're faced with a public health crisis, you need to appear to be doing something, and you need the population to have some confidence that what you're doing is keeping the problem under control. And whether or not we realize it as employees in health authorities, that's some of what's going on. I have to say that it was weeks on the Addiction Day website that the title of my talk was called "What is Fentanyl?" And I have to assume that some of the conference organizers saw my name and thought I was some recently immigrated physician who didn't really have a great grasp of English grammar and didn't understand the difference between a demonstrative and a verb. And so they expected some Indian guy to come up here and talk about, today we are talking about what the fentanyl. The fentanyl is a very, very bad drug. You take it, you die. You laugh, but that's essentially the gist of the Alberta Health Services education campaign on fentanyl. But, so here's a child who's mimicking my expression when I read the newspaper these days. But everybody who reads the newspaper these days on fentanyl I've got to believe, has used this acronym, this WTF acronym, because WTF is going on with this. This is fentanyling ridiculous. In Alberta, to see the crisis escalate to where it is inexcusable. So if I had a newspaper, it might be called something like this. By the way, these headlines that you'll see peppered throughout the talk are actually real headlines that have appeared in newspapers before. But on the fentanyl, you guys have all seen, by the way, I'm sure, the picture of these fake Oxy 80s, which surfaced actually long before media picked it up. But I think, when they started to become rampant, especially at the beginning of this year in Blood Tribe, we started to see these pictures of fentanyl tablets. So WTF, what the fentanyl? It's one of my favorites here. So WTF, when's the funeral? Is the question that one might ask oneself. What you're looking at here is data from the medical examiner's office in Alberta that shows deaths that are caused by acute drug toxicity with or without alcohol that involved opiates, or where opiates were detected on toxicology. You'll see that top line, that kind of bluish-green line, I think that's called teal. The teal line is decreasing after 2012. That's oxycodone. So you would expect to see decrease after 2012 when OxyContin was reformulated into OxyNeo. You'll see that codeine is implicated not necessarily as a primary cause of death, but is found in toxicology in a number of samples, and not really going down that much. Morphine is sort of staying around the same. Hydromorphone is kind of creeping up, certainly is in Ontario. Methadone has come down in terms of deaths that show methadone on toxicology. Fentanyl, in 2012, had taken a huge jump. By 2013, had taken an even bigger jump. And then you also see that bottom line, that orange line, that's heroin. And that's where heroin specifically was detected on toxicology. And we talked about in the opiate talk, we may not pick heroin up specifically, but the metabolite of heroin, 6-monoacetyl morphine, turns up in the pink line, the other line. I don't know why the medical examiner separates these out. The other things that might be included in other, but we don't see a lot of, are buprenorphine deaths, Darvon deaths, for those of you who remember Darvon, tramadol. But for all intents and purposes, anybody an epidemiologist in the room? Okay, you might want to close your eyes for the next thing that I do, because you can't do this in epidemiology, but you can on Photoshop, so I'm going to... So if you combine those two lines, the pink and the orange line, that's what heroin looks like. And I think that's close to a legitimate reflection of how heroin figures into deaths in the opiate crisis in Alberta. So to say that this is a new and emerging problem is, well, a lie. It's not new. It continues to emerge, but it's not new. This is what we were looking at in terms of deaths from opiates, total opiates, right? So those lines before are not exclusive of one another. You may find multiple opiates on toxicology, people who die from opiate overdose and other toxicity. But here's the total number of deaths. In 2011, slightly over 200 deaths from acute toxicity that included opiates. I have this on the screen here. I don't know why I'm turned around. 2012, it jumped up to over 250. In 2013, 291 deaths. The green part of the bar there is rural combined, which is basically anybody except for Calgary and Edmonton, and that's how the ME looks at rural Alberta. Is anybody basically who doesn't have a hockey team. So 291 deaths from acute drug toxicity with or without alcohol. If you added in other drug toxicities besides opiates, the total number of deaths was 387. The total number of deaths from motor vehicle collisions that same year was 358. So acute drug toxicity with or without alcohol was responsible for the greatest number of preventable injury deaths in the province in 2013. It's not because we became better drivers. It's not because we stopped texting and driving. And it's not because of seatbelts. It's because this was rising. If you look at fentanyl alone, what you're looking at, the data points are for 6-month periods of time. If you look at fentanyl alone, in 2013, over the whole year, we saw 66 deaths in 2013. In 2014, we saw 120 deaths. And in the first 6 months of 2015, the first 6 months, we saw 145. In 6 months, we did more than we did in all of 2014 combined. So if you tell this to Microsoft Excel, it can predict what will happen in the second 6 months of 2015. It looks exactly like an epidemiologist. What kind of curve is this? What kind of curve is this? Yeah. Well, You can in a presentation, the microphone is mine. So it looks like an exponential curve. If you put this into Microsoft Excel and you ask for a trend, ask to predict forecast, the formula is forecast. Forecast the next point. By the end of 2015, sorry, those last two should say 2015, not 2014. By the end of 2015, we will have seen 395 deaths involving fentanyl alone. That's more than the number of opiate deaths combined in 2014. And remember on that first slide of the lines of deaths involving specific opiates, most of the other ones weren't going down. So it's perfectly conceivable that by Christmas, we will have buried 500 or 600 people to drug toxicity involving opiates. So WTF, when's the funeral? WTF, Wednesday, Thursday, Friday, every day. Every single day in Alberta, we will have somebody dying from opiate overdose by the end of the year. Here's who's dying. So, and this is only by 2013. I know it's a tough graph to follow a little bit, but what we're looking at there is blue bars for 2011 in epidemiologic age groups, red bars in 2012, and green bars in 2013. Where are we seeing the green bars higher than blue and red? Young people. These are people that everybody should care about, even if you're on the uptight right. And if you think about from a societal point of view, just in terms of the functional role of those people, at 20 to 34, this is when people start having children. This is when people start getting jobs, paying taxes. These are people we should care about whether we like them individually or not. These are their moms. So this is the Moms DU group. Many of you will have met Petra Schultz, who's the third from the left, who talks and carries around a picture of her son, Danny. And Danny was, by all accounts, a terrific kid. Not a kid, he was 25 when he died. He was a Red Seal chef, culinary school in Vancouver, and anybody who's ever worked in a kitchen knows that that's damn hard work. So this is not a kid who was just hopped up on drugs and looking for a good time. This was somebody who had responsibilities and who executed his responsibilities well. And he got in trouble with oxycodone, and then he had a hit of fentanyl, and he died. But if you don't care about people who die from opiate overdose, and if you don't care about their moms, there's still a fuss. This is what we're looking at in emergency departments and urgent care centers in Alberta. And each data point is the number of individuals who attended for emergency care because of poisoning or withdrawal from opiates in the category called other opiates. So the categories would be methadone, heroin, other opiates, and other synthetic opiates. So you can imagine that there's some crossover between how people will report things. But looking at the other opiates category, you can see that the trend is certainly upwards from 2004 to 2015. There's heroin. And look at what heroin's doing. Heroin, from the beginning of 2014, really took a leap. Before, in 2012, if you were to hear the phrase heroin deaths, you would think something horrible happened to Catwoman. But, did you catch that one? But in 2015, we were starting to see heroin turn up in emergency departments and certainly seeing heroin deaths. Other synthetic opiates, which is probably where fentanyl is turning up when physicians turn in diagnostic codes. Do you know what that line is called, even if you're not an epidemiologist? Vertical is what that line is called. So, data people will get hung up on, where is artifact hanging out here? And are people coding things as other synthetic when they shouldn't be coded as other synthetic? Or are they in other opiates when they should probably be in synthetics? So let's take all the opiates together. And between 2014, where we were seeing around 100 visits per month, and now in 2015, where we're seeing close to 250 individuals per month, and recognize that many of those individuals will attend emergency departments and urgent care centers multiple times during that month. So we're not talking about 8 visits a day. We're talking about more than that in Alberta emergency rooms and urgent care centers. So that's what the fuss is about. Okay. So this might be interesting to some of you. I recognize that advertisement might be offensive. Why is everything gluten-free here? I don't understand. So, where's the factory? The factory is basically most of the fentanyl that's on the streets in Alberta is coming from China. And you can buy it retail online on the open web. This is not darknet, this is the open web. You can buy fentanyl retail for about $12,500 per kilogram, shipped to your door, guaranteed delivery. Which means if it doesn't show up, if it's seized by a customs agent or such, you can call or you can email your seller on WayQ or any other of multiple retail sites. And by the way, November the 11th was International Shopping Festival in China. There were discounts on fentanyl. And I didn't take a screenshot, but it was quite impressive. I was tempted. You can also buy it from business to business or B2B websites. And here you're seeing acetylfentanyl, which we're seeing much more of. And the tox labs are reporting that almost every single urine tox screen that comes back positive for fentanyl is actually acetylfentanyl. So ironically, the most important public health intervention that's occurred in this fentanyl crisis, in my opinion, has been the drug dealers switching from fentanyl, which is about 7 to 10 times as potent as acetylfentanyl. This is here. So acetylfentanyl is for the Walmart-looking price of $6,999.97 for a kilogram. It's $40 per gram and $7,000 per kilogram. What does that tell you? Like bulk discount, obviously, but if you were buying a kilogram at gram increments, it would cost you $40,000. But if you buy a kilogram at a time, it costs you $7,000. Where's most of the cost here? Transaction cost. It's not the drug. The drug is cheap. It's transaction cost. So we're up against a real challenge here. So you get your kilogram of fentanyl or acetylfentanyl. You need a commercial mixer, and then you need a pill maker. This is a pill maker, a pill press, a manual one. You have to rotate this yourself. But you can still make hundreds of pills in an hour. If you're more ambitious, you can buy a commercial pill press, which is not regulated in Canada, regulated in the United States, but not illegal anywhere in North America. You can get one of these. This was one that was seized by the Calgary police, and the owner of it just said, you know what, just take it. I don't want to have an investigation or anything like that. Just take it. I don't really need it. I'll get another one. And these are dyes that you can buy online to make your counterfeit Oxy 80 pills for $1.58, by the way. American, so about $12 Canadian. So here's how the numbers crunch out. $12,500 for a kilogram of fentanyl. Remember, when we measure fentanyl doses, what do we measure it in? Micrograms. So assuming that a euphoric dose should be, slightly under a milligram or 1,000 micrograms of fentanyl, from 1 kilogram you should get 1,000,000 milligrams, which means 1,000,000 tablets, and on the street, $20, $25, $30 a tablet. Your return on investment, 160,000%. But if you spend $100,000 in capital assets, right? Because this is your first batch you're making, so you have to put in the fixed cost. Well, it's a piddly 18,000%. But you can't even make that in Bitcoin. Nobody's heard of Bitcoin. All right. So it's easy to see how we'd get really angry at these drug dealers who are making hand-over-fist money from fentanyl, and why we should attack them in our public awareness campaigns. And that's what we decided to do, was a public awareness campaign. What a novel idea. A public awareness campaign for drugs. It's terrific. Not so much. You remember the National Youth Anti-Drug Media Campaign in the United States between 98 and 2004. And when studied in 2008, they were trying to see whether or not attitudes towards drug use had changed in a significant way for people who were exposed to that campaign. And what was found, as most of you will know, is that there was no effect of the campaign from most analyses. And in fact, at one round, at one study point, more ad exposure predicted less intention to avoid marijuana use. You ever heard of DARE, by the way? Everybody's heard of DARE because DARE is everywhere. And this comes from Dr. McLennan, who's our very own from Community Health Sciences and Psychiatry and Pediatrics at the U of C, who wrote much more eloquently than I did. See, the way that I think of it is it's sort of like your creepy uncle who tells you to pull his finger, and you do, expecting that this time something good will happen. Nothing good ever happens, and sometimes bad things happen when you pull your uncle's finger. And also, sometimes bad things happen when you do things with no evidence. So basically, what Dr. McLennan showed is that a school that's adopted DARE, which doesn't work and probably does harm, is also quite unlikely to adopt a second substance use prevention program or replace DARE with something that works, because they can tick off the box that we're doing something about drugs. So it removes the press to do something else. And remember, I talked about conflicts of interest and how health authorities necessarily have to try and demonstrate that they're doing something about emerging problems. Well, if you can say, yes, we're doing a public awareness campaign, well then you have that for your media lines and you have to say less things. Here's something that troubles me as well: the language that drugs fool. So if you're an addiction doc or somebody who works in addictions, you will have an appreciation for why this is somewhat troubling. What we're suggesting to people who see this ad is that you shouldn't take this drug because it'll kill you. And if you didn't know that, now you do, so you shouldn't use. Assumes that somehow they have control of their compulsions and that they will not use if they know the consequences. Do you remember the 4 C's of addiction? They can't do that. And what we're telling them is that if you can't exercise conscious volition over this, you're a fool, or you've been fooled by the drug dealer. But my question is, WTF, who's the fool? And I don't mean to call anybody out in particular, but on March the 10th, our Coalition on Prescription Drug Misuse had our penultimate event, which was it was a gathering of people who were decision makers to come up with concrete solutions to our access to opiate dependency treatment problem. And at the time, I presented much of the same data that you saw for what we were seeing in terms of fentanyl deaths. And what we heard from one of the, by the way, quite bright, very bright clinician, an intelligent man, what we heard from him was, it isn't a big problem, it's a complex problem. And I'm not singling him out because this is verbiage that we've heard a lot when dealing with when hearing about opiate dependency. It isn't a big problem, it's a complex problem. Well, that's a vertical line. Looks to me like that and that amounts to a big problem. As for complexity, well, there's only 3 things you have to do to address an epidemic of opiate overdose death. One is safe injection sites, and I'm glad I no longer work for the federal government under Stephen Harper because I've been told I would spontaneously combust if I said that term. The second is naloxone distribution programs, and the third is agonist maintenance therapy. It seems simple to me that there are 3 fixes, and we have to improve access to those, and move pieces around from things that don't work into these 3 things. And as we talked about at the opiate talk earlier today, the things that don't work actually kill people. Doesn't seem complex. We should do what works and we should do more of it. So as for safe injection sites, it's kind of, I think it's funny that Stephen Harper looks baked when he's giving his anti-drug strategy talk. And it's possibly the only explanation for what he said. The data's mixed on Insight's efficacy, he said. Well, to be fair, on one side, you do have very convincing opinion polls of people from the uptight right that say some people really don't like safe injection sites. So that's one side of the mixed data, and then on the other hand, you have science, and then you also have the Supreme Court, thankfully. But Stephen is Stephen, and he whatever helps him sleep at night. So that's safe injection sites. What about naloxone distribution programs? So some of you might remember that in the early part of the year, very troubling stories were coming out of a First Nation community in the south part of the province, who, by the way, has a lovely chief who was extremely invested in dealing with this problem in any way that we could entertain. And in February, we sent out, and when I say we at Health Canada, I mean a guy with a prescription pad who had a tendency to not ask permission to do things, and a pharmacist who wanted to do some good and who had access to wholesale suppliers, and a couple of clerks at the drug distribution center who had the time to go to Dollarama and pick up those Tupperwares that you see here and get her done. And so we sent the first 47 naloxone kits, and I'll explain to you the complicated calculation that it took to come up with that number, and a couple of docs in the community to assist with training, a couple of good crackerjack docs who were very, very invested as well in this problem. And at the end of March, we made sure, no, sorry, I shouldn't say we made sure. Something happened, and the press showed up to cover the training of the individuals in how to use naloxone. That was March the 26th when that came around. Nothing happened in the province right away. I'm an impatient person, so I wrote an op-ed. And after that, I was told, Keek, the minister's not very happy. And I said, wait till October 19th, she'll really be unhappy. And we used the question in the op-ed. At the Blood Tribe in southern Alberta, a state of local emergency has been declared in response to this problem. The RCMP have charged traffickers of fentanyl with criminal negligence causing death. What responsibility should our health system bear for its negligence in not providing treatment? And the next day, one of the champions of this, and a hero of mine, Dr. Jim Talbot, who's our former Chief Medical Officer of Health, announced with the endorsement of the minister, maybe not the deputy minister, but the minister, that the naloxone program would be expanded to the province of Alberta. And at the time, I can't play you this video clip because this is just a screenshot, but Jim said something that I thought was very heartening. He said, it's a measure of the compassion of us as a society to recognize that every death is tragic, but the preventable ones even more so. And we have an opportunity to do something about it, so we should. That sounds to me like an excellent motherhood statement, but unfortunately a politically charged one for people who didn't like that this happened. And in June, this was the headline. I'm not saying that you should connect the dots in a straight line, but you might. Here's what Jim said at the end of his tenure. When the Deputy Minister of Health informed me that my contract as the Chief Medical Officer of Health for the province of Alberta was not going to be renewed, she made a commitment to me that I would be able to make and circulate a final statement. That has not occurred. But thankfully, after Jim left, we had another hero take on the charge inside the ministry. He's a handsome man who's amongst us today. Michael True, Dr. Michael True, who was the province's Chief Addiction and Mental Health Officer. Well, why not? He thought the vision and scope of his job had expanded. True spoke publicly about suicide prevention, including the number of deaths on the high-level bridge in Edmonton, and harm reduction issues related to fentanyl, naloxone, and methadone. So Jim's not working at Alberta Health. Mike's not working at Alberta Health. Keek's not at Health Canada. Naloxone saves lives, but it friggin' ruins careers. I think the point is that while governments change, bureaucracies can remain very, very ugly, and it's up to us to ensure that that doesn't affect patients. That's the point. By the way, after all of that, come on. They got rid of us, but Nick Etches pulled out from the back of his pocket, I still have something. You can make this go away. So certainly Nick, who I'm proud to say is a former student of mine, has been a champion in the absence of people in the ministry in making sure that naloxone gets into the hands of people who need it. He will be the first to admit that it is not yet in the hands of people who need it, but knows exactly what needs to occur for that to happen. By the way, I think because he was probably in Kumon classes in utero, he thinks in numbers. And so the 3 fixes actually come from Nick. And if you have a chance to meet him, it'll be very interesting. You'd shake his hand, he'll say, "Hi, I'm Nick Etches. There are 3 ways to prevent opiate overdose." So the third one, of course, is opiate agonist maintenance programs. And we would be thrilled to get the kind of attention that medication-assisted treatment has gotten in the United States of late. I believe that if Obama was running his first campaign now, his motto wouldn't be "Yes, we can," it'd probably be "Yes, Narcan." Because he seems to get this. This is a headline from the Huffington Post from a couple of weeks ago. Obama tells outdated opioid treatment industry it's time to change. This is an order that came directly from the Oval Office. This wasn't just a shill for Obama. This was him saying directly, if you're a federal agency with healthcare responsibilities, you have 90 days to identify barriers to medication-assisted treatment and address them. We sent naloxone to Blood Tribe in February. It's November. We've been talking about agonist maintenance treatment access for 8 or 9 years that I've been involved, and I'm not that old. So this is, 90 days, that's thrilling that Obama has put that kind of pressure on. And SAMHSA said, if agencies who provide treatment or treatment industry must follow the evidence, we've made that clear. If they want our federal dollars, they cannot do that, which means offer only abstinence. And interestingly, this was partially in response to an investigative piece that Huffington Post did. I'm not sure if any of you have seen the series called Dying to Be Free. It was a series of articles that was written in the Huffington Post where they actually reviewed 93 deaths in Kentucky from opiate overdose and found that the vast majority of them had actually attended treatment in the months before dying, and those were abstinence-based treatments. Here's what's happened in Alberta. From 2010 to 2014, this data comes from the College of Physicians and Surgeons of Alberta. This is the number of people who were receiving methadone solution or buprenorphine naloxone. The increase has not been nearly enough. when we know what's going on with opiate use disorder. And in fact, the trend is probably artifactual because we know how much Suboxone is now used in pain management. So really, these are unique individuals who have received a prescription for methadone solutions or Suboxone, and we're probably seeing that the people on agonist maintenance treatment for opiate use disorder is staying about the same the last 4 or 5 years. The curve doesn't look nearly as steep as this does. It should. It's not even as steep as our increase in deaths, and it should be that. And it's certainly not as steep as what we're seeing with fentanyl. This is just from last week in the Public Library of Science in Scotland. They, sorry that's cut off, but what they showed was that people who were discharged from hospital who had a history of injection drug use were multiple times more likely to die in the 28 days following than from any other reason for hospital admission. So basically, I think the point is that every touch point in our healthcare system with a person who's struggling with opiate use disorder is an opportunity to provide naloxone and to refer to treatment or start it yourself. It's not that hard. In public health, we approach risk in a very elementary way where we look at hazards, all hazards, which are mitigated or modified by your exposure and susceptibility, and that translates into risk. And we have some high-risk populations amongst us, like people who are recently discharged from residential treatment facilities, from detox, people who are recently released from jail. We talked about these people in the opiate talk. They're very important. But what's changed with the fentanyl crisis is that the hazard itself is so much more poisonous than most of the other opiates, or than every other opiate that we've seen on the street. The likelihood of exposure is extremely high. I can't tell you the number of kids who we treat in clinic who have used fentanyl, have never smoked weed, or drank alcohol. And oftentimes in conversations with, pain docs or whomever, or abstinence-based treatment, they talk about how, really we've got to get to the root cause here, and somehow kids are just not coping with stress the way that they used to, and the quest for a higher high is really the problem here. And to me, aside from using social media more and believing that Justin Bieber has talent, I really can't think of a lot of ways that the human condition in childhood has changed that much. What we know is that drugs become abusable when they create a high, when they have a characteristic withdrawal syndrome, where the withdrawal syndrome will abate if you take the drug again, when those things happen quickly, and when the drug is available. Fentanyl is extremely available. It's very, very cheap, and it's everywhere. In terms of what the ministry's response has been, so in August, we heard from Alberta Health that efforts are underway to open up access to treatment, and the way that that's being done is that the department has decided to use a generic and cheaper form of Suboxone on formulary, and that if they get word out to the rest of the province, and that officials have been trying to get the word out to doctors that there's a cheaper form of Suboxone now, so this should increase access to treatment. Where's Cameron Barr? So would a cheaper form of Suboxone increase access to treatment for patients who attend Boyle Macaulay?
No, because they can't afford to pay for any medication.
They don't pay for any medication, and they would be on a publicly insured plan. The new one tastes like shit, though, yeah. That's what we hear. So Alberta Works covers Suboxone and the generic forms of Suboxone as an open benefit. But really, if that's the response, here's what I say. And you can see the eyebrow raised so as to say that, because we couldn't put in print what I was thinking. By the way, since we were open at the beginning about conflicts of interest, I know that Mylan is here, has a booth at the conference, but The generic form of buprenorphine naloxone is produced by Mylan, who, by the way, in September 2013, doubled down on their production capacity for transdermal patches that include fentanyl. Talk about making money coming and going. My goodness. But really the point is that if you make buprenorphine naloxone cheaper, it may benefit people who would otherwise be paying cash for their medication. But for people who would be on income support, and most people seeking out treatment are no longer socially productive when they do, and would be eligible for publicly insured medication coverage, this makes no friggin' difference at all. So this is from this morning. I'm very happy to say that Nick's Big Three made it into, and can we, just for the sake of me feeling like this talk was worthwhile, can we recite the 3 big fixes? Come on. Safe injection sites, naloxone distribution programs, opiate maintenance treatments. Thank you. Now, all of Canada knows because it was in the Globe and Mail. And I hope that you'll tweet the crap out of this, because I would love for everybody to see that the solutions to this are not, they don't have to be complex. Yes, it's difficult to get physicians to do things that you want them to do. Yes, it's difficult to move pieces around in a complex system. But really, if we want to do it, we will. We had conversations in the opiate talk earlier this morning that, how do we best perform advocacy to get this stuff done? And I think that, I jaded pretty quickly, but in my short career so far, what I've recognized is that idiom that you should be the change that you want to see really is quite true. And I'm not trying to, I don't eat quinoa, I don't wear fleece, and I'm not a social activist, but it is true. It's very, very true that being the change that you would like to see is effective. So if you're upset that there's not enough access to opiate agonist treatment in the province of Alberta, provide opiate agonist treatment in the province of Alberta. Do it as part of your practice. If you're upset that naloxone distribution programs are not as widespread as they ought to be, if you're a physician, prescribe naloxone. It's $50 for a kit. We've paid for naloxone for patients before if we feel like, I'll see them, it's a visit, and I'll use that visit to pay for the naloxone. Or if the patient recognizes that saving a life could cost $50, at least offer them the chance to pay for it, and it's a prescription drug at the moment. Maybe JT in Ottawa can make that different, but at the moment it's a prescription drug. Write a prescription. We don't have the opportunity to set up a safe injection site in your backyard. That might be safe for them, might not be safe for you. Your neighbors won't like that so much. But at least for 2 of them, you have a role that you can play. And so be the change that we would like to see, so that we're not saying this forever. And that's my talk.